Hi, everyone. Good morning, good afternoon, good evening, wherever you are. Thank you for joining us today. Um, just wanted to welcome all of you to our session. We are really pleased to be talking about this important topic about ensuring that services are equitable and available to, especially to vulnerable populations. So some of you may have seen there was a recent Lancet article that documented the overall reductions in morbidity in low and middle income countries, really highlighting the ways which, with the exception of this COVID blip, health systems have been doing better by many citizens. But I think as we see global health strategies that are increasingly embracing the dual goals of reducing morbidity and improving well-being, I think that amongst our panelists, we continue to be concerned about ensuring that underserved vulnerable populations, such as people with disabilities, older people, people with mental health issues, among the different groups that are not well served by existing health programs, so neither existing services reach them in ways that correspond to their needs, nor do they have access to the specialized care that they also need. And so today's conversation is about what do we need to do to really talk about health services for all and services that both reduce morbidity, but also promote well-being. So I'm pleased to introduce our panelists. We bring a breadth and depth of experience to this conversation. First, Alessandro Arasu, who's the Director of Global Inclusive Health and Protection at Humanity and Inclusion. She's been a leading voice in promoting gender, age, and disability inclusion in the health sector, especially with a focus on health equity for people with disabilities. Also happy to have my colleague here from the Fred Hollows Foundation, Vanya de la Fuentes Nunez, who's our Healthy Aging Advisor. She's an expert on healthy aging and has been leading the Foundation's Healthy Aging program. Before joining Fred Hollows, she led the global campaign to combat ageism at the WHO and has co-authored their landmark global report on ageism. Also pleased to have here Anne Hayes. Anne is the co-founder and executive director of Inclusive Development Partners. Anne has been more than 30 years of experience working on disability inclusive development and education efforts. She's worked in multiple countries. She's both within donor agencies and implementing groups, as well as now providing technical advice to a range of organizations. So welcome to have her experience. And finally, we have Dan Taylor, who's here. He's a founder and leader in Mind Freedom Ghana. So Mind Freedom Ghana is a mental health, human rights, and development organization that works to channel and align projects with the needs of people with mental health. And so he's really been an active advocate for mental health in Ghana, and I think has informed the global conversation around serving people with mental health needs. So you can see we have a panel that really brings a range of perspectives to this issue of addressing equitable access to care. So what we wanted to do is have a conversation around sharing our different perspectives. I'd like to encourage you, if you have questions, to go ahead and post your questions in the chat. So to kick off the conversation, I wanted to start with a question for the group. So the first question, I think, is I'd like to ask each of you to talk a little bit about the current state of access to care and how that affects vulnerable groups. So maybe, Alessandra, we could start with you. Why don't you share a little bit about your thoughts on the global landscape and access to care, especially for people with disabilities?
Perfect. Thank you, Beatrice. Good morning, good afternoon, good evening, everybody. I hope you can hear me well, and I'm glad I managed to connect. I had a moment of difficulty technically. Thanks for your question, Beatrice. And indeed, it is important to reflect on access to health information and services when it comes to persons with disabilities, especially because not enough throughout the years have been said on the topic. And this because often we didn't have enough data available on the subject when it comes to qualitative comparable data that reflect really the access to information and services that persons with disabilities could have. Today, we have more information also thanks to additional research that have been taking place. But what can we say today is still that globally, persons with disabilities that account for 1.3 billion people around the world, 80% of which live in the global south, often in the countryside or in rural areas. They face a lot of challenges in accessing health information and services. And particularly if we look a little bit at the data that we have available that come specifically from WHO, we can clearly say that persons with disabilities are more discriminated in accessing health information and services globally. This because of physical barriers, but also when it comes to attitudinal barriers related to the health workforce and communication barriers that are facing when we are within the clinics. In particular, however, we know that persons with disabilities are 3 times more likely to be denied healthcare, 4 times more likely to be treated badly when accessing health services, 50% more likely to suffer catastrophic health expenditures. They face also a life expectancy gap of 10 to 20 years all around the world as a result of the health inequities that they face when trying to access health information and services. Again, when it comes to women and girls with disabilities, this gap is even bigger. We know that 3 times more women and girls with disabilities are 3 times more likely to have unmet needs for healthcare and 2 to 4 times more likely to experience violence. These are for the barriers that I was referring before. We know that is linked to health inequities and not to and therefore to barriers that can be addressed and removed. I will pause here because time is precious, and I give it back the mic to you, Beatrice, just as a start. Thank you.
I think that's a great kickoff. Vanya, do you want to jump in and share a little about the specifics of how older people experience access or lack of access to health services and healthcare?
Sure. Thank you, B, for passing on the mic, and thanks, Alessa, for the wonderful introduction. I agree. I mean, a lot of the messages that Alessa was sharing are similar to what we find when we specifically focus on older populations. The sad reality is that in most countries, and particularly low and lower middle income countries, where the vast majority of older people actually live, by 2050, 80% of older populations will live in these countries. And healthcare services are simply not designed with older populations in mind. They're not designed for older people. And as a result of this, we see services that are fragmented with numerous healthcare providers being involved in one single person's care, not necessarily coordinating the care, which often leads then to polypharmacy and many other issues experienced disproportionately by older populations. There's also, similar to what Alessa was saying, inadequate access to health information, which means that older people may not recognize, for example, early symptoms of conditions like diabetes, heart conditions, or dementia, or, which we see so frequently, incorrectly assume that many of these conditions and symptoms are an inevitable part of aging. This obviously leads to delayed diagnosis and treatment, which worsens then their health and increases the risk of complications. If that were not enough, services generally are too far from where older people live and often too expensive for them to afford them, which renders them effectively, I mean, inaccessible for older people, right? And forces them to make really hard choices between, for example, choosing to access healthcare or basic essentials like food or housing. And these decisions are not necessarily always made by the older person. So, for example, if they live with other members of their family, these are decisions that are oftentimes not made by themselves, which we see tends to lead to then the healthcare needs of older populations being deprioritized. So they will never reach those services that are there. And like I said, I mean, even in the cases where older people do manage to access services because they are not designed with older populations in mind, and just think that, the time when our healthcare systems were designed, they were designed with a different population group in mind, generally younger populations with acute health conditions. These are not the conditions that we see as we get older. We tend to have more complex and chronic conditions, and the health systems that we have are not able to respond to that. And we also encounter negative attitudes and ageism of the healthcare workforce, which then means that the conditions and the symptoms that older people present are often dismissed or overlooked as normal signs of aging by healthcare professionals. So they're not actually ever treated. So again, this just means that, older people will generally have this lack of interventions that are specifically tailored to them. And they're also then not able to access the services because they're too far. There are these misconceptions. There's pervasive ageism in many countries. And then because they're also not designed with older populations in mind, this also means that specific conditions and services that are essential for this population group are just not there. I'm talking here about, for example, interventions that will deal with cognitive decline or improving access, for example, to assistive technologies. So again, huge barriers currently because older populations are just not thought of when we're designing these services and thinking about delivery modes.
Dan, would you talk us through a little bit of the country level perspective on what you see as the impact of this lack of support, especially for people with mental health disabilities, mental health challenges, how you see that at the country level in Ghana where you're working?
Hi, good afternoon and warm greetings from Accra, Ghana's capital. I've had a lot of challenges with the internet, but so I'm just fortunate to have been able to get through right now. It really made me feel distraught. At the point in time, I wasn't able to access the internet, but just fortunate to have been able to go through. Thank you for this opportunity to join this discussion. And well, I would say I've been able to go through with the two earlier speakers, what they said in terms of the global perspective and other issues. Now, in terms of Ghana, what I was saying for people with mental health conditions to access services is quite a challenge, but then it's been addressed gradually. And it might interest you to know that we have the three major psychiatric hospitals in Ghana, in the southern part of Ghana. But then by the mental health law that we have in Ghana, we now have mental health units or wards in all the regional hospitals in Ghana, where people are able to access services. But as to the level of adequacy of services, that's another issue. And then we also have people accessing treatment at district hospitals in Ghana for mental health conditions. Another major challenge that I want to talk about are medications. Medications. That's also a major issue in terms of people, once they are diagnosed, and then they are given the medication. Some of them are not able to afford, or they are able to afford, but in course of time, because of periodic reviews, they are not able to continue to buy their medications, and that tends to make them, have relapsing conditions. So in terms of some of the challenges, or to be able to access services in Ghana, these are a few things that I want to mention for now. But as we go on with the discussions, I can come up with other issues together. Thank you.
Thank you. I think that those comments really reflect the size and scope and importance of serving these diverse populations who are still not fully benefiting from the health systems in the countries where they're living. So maybe you could talk a little bit about what the current state of global governance is for health services and where you see progress in laying a foundation for access, improving access, availability, quality. Alessandra, maybe you would give us a start on this by talking a little bit about recent progress at the global level. What makes you think that we're moving forward in addressing these needs?
Thank you, Beatrice. As I was referring before, throughout the years, this topic of promoting the health equity for persons with disabilities, ensuring that the right to health for persons with disabilities is fulfilled by everybody, was not a top priority, neither in the global health context within discussion on health equity overall, or within the disability movement that has somehow prioritized other topics like education or employment and less the right to health for historical reasons that here we don't have the time to get into, but just to say that maybe if we have a couple of minutes, we can also look into the reasons that brought health equity for persons with disabilities a little bit lower in the priority of the discussions. Today, and after a lot of advocacy done by many organizations, including Humanity and Inclusion that I represent throughout the years, we have a better scenario in front of us. We have a WHO that has published only 2 years ago the very first global report on health equity for persons with disabilities. That is, I'm putting the link on the chat so that everybody can access it. It is a long document, but is extremely rich and extremely important. It was created as a result of the very first World Health Assembly resolution on the highest sustainable standard of health for persons with disabilities that was adopted at the World Health Assembly in May 2021. And that really where member states requested WHO to produce this document, among other steps, to be made to promote the health equity for persons with disabilities. As a second step from this report, today there is a really freshly published guide to action that is really an information sheet and some practical recommendation on how to really translate the recommendation within the WHO report into practice. These are practical steps primarily for member states who want to strengthen their health system and really make the health system more inclusive. But of course, the richness of this report, it's really in the data that are quite updated compared to what we were before, and the analysis of the barriers as well as of the facilitators that can be addressed, and all the concrete steps that can be taken to promote health equity for persons with disabilities. I will once again stop here because I'm conscious of time, but I'm happy to go back to this document again if we have more time during the conversation. Thanks, and back to you, Beatrice.
Vanya, maybe you would also extend what are global advances in recognizing this growing need for care for older people. What do you see as significant steps taken that are advancing the issue?
Thanks, B. For the sake of time as well, I will focus on perhaps just three key advances that I think is worth sharing today. The first one is the UN Decade of Healthy Aging. This is currently underway. It started in the year 2021 and will last all the way up to 2030. It provides a global collaboration that brings together diverse stakeholders and sectors to improve the lives of older people, their families, and communities. And in this way, it has this plan of action that provides every single stakeholder, an agenda, so that we can have this coordinated action up until 2030. It focuses on 4 key areas. Some of them, they're all in a way related to health, but they're not all only specifically related to health. The first area is combating ageism. As I mentioned earlier, we live in societies where ageism is very prevalent. We have data released in the Global Report on Ageism that shows that 1 in 2 people are ageist against older people, with rates being much higher in low and lower middle income countries. Unless we address ageism, it's going to be very difficult to design policies and programs that are actually effectively addressing the needs and preferences of older people, because they're going to be misguided by whatever misconceptions policymakers and those designing programs will have. So that's the first action area of the decade. The second is the need to create age-friendly environments. This goes all the way from creating infrastructure that is age-friendly to delivering policies and programs that enable, for example, the active participation of older people. The third action area that is more directly related to health is about providing integrated care for older people. Again, this is thinking about what type of services and what type of healthcare systems do we need to actually respond to the needs and preferences of older populations. And the last action area of the decade is around ensuring access to long-term care when we need it. Obviously, not every older person will need long-term care, but a percentage of older people will. So again, the ultimate aim of this agenda that, takes us together on a global path for 10 years is to make healthy aging a reality for everyone. Because the other thing that we also see is that there are huge disparities both in longevity, but also in healthy longevity. So obviously not every person, depending on where we live, in which country we live, and even within country, we are more likely to live X number of years, and we're more or less likely to live X number of years in good health. And we need to address those disparities to make healthy aging a reality for everyone. The second advancement that I think is important to highlight is the consideration of a UN Convention on the Rights of Older Persons. Alessandra was just talking about the great strides that have been made in the field of of persons with disabilities. And in part, and I would probably say in large part, this has been thanks to the fact that there is a UN Convention on the Rights of Persons with Disabilities. We don't have such an instrument when we look at older persons. And we are actually in a pivotal moment right now in terms of the possible development of this convention. So no convention currently exists, but in August of this year, during the 78th session of the UN General Assembly, member states basically adopted a very important resolution that does mark the first step or substantive step really towards a potential UN convention, which could provide legally binding obligations, right? Like we have with other conventions for countries to safeguard older people's dignity, autonomy, and access to essential services, including, of course, healthcare services. This is very important as well because legal scholars and many NGOs and other organizations working in the space have been flagging again and again the substantial gaps that currently exist in existing human rights frameworks. So we don't have enough protections in the existing human rights frameworks to actually be able to safeguard the rights of older persons. So again, we would need such a convention to make that happen, but we are in a position where we could potentially be getting to that endpoint. And the last advancement that I would like to perhaps share today is what we are seeing from countries, right? So we are seeing a surge in the number of countries that have introduced laws or policies aimed at responding to the needs and preferences of older populations, including in the area of healthcare. So for example, age-friendly policies, but also laws against age-based discrimination across a range of spheres of life, including healthcare plans, et cetera. Just to give two key data points. So in the year 2020, for example, a total of 105 out of 164 countries had a national plan or policy on aging and health, which increased to 108 by 2023. Similarly, the number of countries with legislation or regulations that provided older people with access to assistive devices from the WHO priority list, it went up from 59 in 2020 to 78 in 2023. So yeah, we see advancements, but there's still significant gaps. So oftentimes these global and national frameworks struggle to translate into effective on-the-ground implementation. So we end up having very polished and nice looking policies and laws that have no real effect on the ground. So again, we need to make sure that they are implemented. And I mean, some of the underlying reasons why they never result in implementation include underlying ageism of policymakers, resource constraints, limited enforcement, et cetera. Perhaps we can discuss those later on in a bit more detail. But yeah, I mean, I would say I'm optimistic. I think we've made strides, but I think a lot more needs to happen. Over to you.
I think that's really interesting. So I think you get a feel of sort of what's happening at the global level. And I think you could talk a little bit about a bridging piece, which is how large donors like USAID use their resources to advance this as part of health programming or other programming. So I wonder if you'd want to comment a little bit on one potential kind of bridging, sort of that bridging role that donors play.
I mean, donors can demand. Sorry.
Oh, hold on. Let me ask Anne, and then Vanya will hold off and come back if that's okay.
Okay.
So I think, requiring donor or sort of inclusion of marginalized groups is not new. USAID started its policy and was groundbreaking at the time in 1997. And since then, most donor agencies have some sort of policy. And USAID just released its new disability policy a couple of weeks ago, which is very exciting. But not surprisingly, like most laws within countries, there's a big gap between policy and practice. And I'm sort of a geek when it turns to solicitations and using them as a way to analyze. And I've done a series of analysis looking at what happens in solicitations, because we know what happens in solicitations sets the role for large funding, especially in health and education. Interesting enough, the sector that was started, we looked at in 2015, health was the least inclusive of all the sectors. Education, what Alessandra said, was the most inclusive of all the sectors. We looked again in 2021, and it still was the same. It's a little bit better. 15% of health programs had a significant requirement of inclusion compared to 38% of education projects at USAID. And another thing of research that I thought was very interesting is that in 2018, I did some research with Chemonics about the word marginalized groups or vulnerable groups. And what we found was that this was very subjective. And when you had this sort of broad term, what happened is that whoever was implementing it implemented the way they understood marginalized groups. And that was almost always gender and youth, but rarely was LGBT, and rarely, we never saw elderly or elder populations coming up, and also rarely persons with disabilities. And then what happened is in the reporting, those groups were never really addressed. And we found often if there was sort of vague things like include marginalized groups, then we'd look at reports, and the reports would say, oh, and we included marginalized groups, but it didn't really say what's happened. So I think there's definitely, I'm hoping with this new policy, we're going to see more requirements, and that, where the funding is and where, people are responsive. So I'm optimistic that we'll start seeing diversity going beyond gender, which obviously is important, but also looking at intersectionality. We too often start thinking that we just have one marginalizing factor, but in reality, most individuals have multiple layers. They may be an Indigenous girl with a mental health challenge, and what are we looking at there? So. You're on mute.
Yeah. So interesting to sort of see the global frameworks coming, advancing, opportunity for key connecting agencies like donors to really move this toward more operational work on the ground. I think that's where we should turn next. Let's take a minute to talk about one example of what each of your organizations is doing to advance health equity in a very in a practical way. And then we're going to turn, for those on the call, we're going to turn to talk a little bit about what concrete steps audience members can take. So again, just want to invite audience, those of you who are listening, think about if you have specific questions, feel free to put them in the Q&A. And we should have time for questions as well. So let me circle back. Let's take examples of how each of your organizations is advancing access for specific groups that are otherwise underserved. Maybe let's start with Vanya. Vanya, do you want to talk a little bit about healthy aging and pilots to what you found with Fred Hollow's work on healthy aging?
Sure, and maybe before I delve into those details, I wanted to take a step back because this also links back to what Anne was mentioning right now. And I think in terms of what donors can also be thinking about. And I would say that the starting point in any organization, but also donors, in a way should be to look at the ultimate goal of the organization, or in the case of donors, of whatever call they're putting out there, and then see who the organization is reaching and who they're not reaching, and how all of this then relates back to the goal. For example, at the foundation, what we did is we started looking at where the prevalence of avoidable vision loss lies, and we saw that 73% of cases are among those who are 50 and over. So obviously this signaled to us that we needed to have concerted efforts to reach older populations, right? And I mean, to a large extent, this huge proportion of cases of avoidable vision loss in this age group are due to poor access to a very simple and cost-effective operation, which is cataracts. But obviously, depending on where you live, you will have access to this or not, and you will believe in this type of surgery actually being able to derive positive outcomes, right? So what we did in the projects that we were running was to explicitly design projects to deliver eye healthcare services for older populations. And where possible, we delivered integrated services for older people, which included eye healthcare, but also other areas that are key for this population group. And we carried out projects in 5 countries in the year 2023. These included Vietnam, China, Ethiopia, Kenya, and Uganda. And they were designed to respond to some of the challenges that I was mentioning earlier, but also to some context-specific challenges that we identified in one location. I'm going to give an example. In Uganda, our needs assessment revealed that older women, and here we're talking about is intersectionality again, which I really like that comment that Anne brought in. Here we saw that it was older women within the older population group that were very affected by poverty, which then also affected their access to eye healthcare. So to respond to this, we specifically targeted older women, and we also had concrete targets to reach this subpopulation in the projects. Some key aspects that we consider were how to bring services to the community, again, making sure that they are accessible in terms of how close they are to where older people live, how to build the capacity of the healthcare workforce to be able to deliver services that are designed for older populations in mind, and also that are unbiased, so that an older person does not get to a clinic and receive comments like, oh, you have pain on your knee, that's normal for your age, right? That the conditions that they present are actually taken into account by healthcare providers. Also, how to engage older populations. This is incredibly important because in many communities, older populations may not trust existing healthcare services given their past interaction with the services. So it's very important to ensure that we are working with older people's associations or OPAs in the communities where we work to jointly design the projects, and where that process is not available for whatever reason, at least to engage them in the process of mobilizing older people in the communities, because they will then trust the services. And last but not least, and again, going back to that comment about intersectionality, how do we reach older populations in their diversity? Because if we don't have an equity lens in the programs that we're having, we're going to end up reaching the easiest to reach within the older population, which are going to be younger older people, are going to be most likely men, are going to be those living in urban areas, and those without disabilities. So again, we really need to have this equity lens in the design of our projects to ensure that we reach that full diversity, and that we're specifically targeting those who are more likely to be disadvantaged and have less access to healthcare. And yeah, by doing this, I mean, what we saw was that we were able to respond at very significant unmet need. In fact, in some cases, we were not even able to respond to the full need that we detected, which signals the need to do more. We also achieved substantial improvements, not only in cataract surgeries, et cetera, but also in terms of improvements in health and quality of life of older people. And then there were those efficiencies gained both for individual older people, but also for healthcare providers that were resulting from having integrated care, which, I mean, has been seen we confirmed this, right? This has been seen in other settings as well. So again, these are some of the lessons learned and some of the factors that we considered very briefly. But yeah, back to you, B.
Yeah, thanks. I think that's a really interesting pilot, and I think it's kind of a nice segue to hearing from Dan about how Dan and colleagues grew Mind Freedom Ghana, because it touches on some of the same issues, and particularly the importance of engaging with the communities that are in need of services. So Dan, let me hand it over to you, and you want to take it from here and talk about what you've been doing? You're on. You might be on mute.
Yeah.
There you go.
I unmuted myself. Yeah, thank you. Yeah. So in terms of the community engagement, I had mentioned in our previous meeting about our community awareness and creation activities. So we're able to go into the communities. We have education and awareness activities with them, and then we'll tell them what they need to be looking out for and where they need to seek, treatment and other services for their conditions. So that helps a lot. And of course, you also have community health nurses who go out there into the communities. They engage the people right at their homes and within their communities, and they are able to talk to them and really, they get that kind of engagement with the communities to be able to know at first on what their concerns are, where they also need to seek, they need to seek treatment and all of that. So what is most important I can mention is that we're looking at the primary health care, which is very, very important, so that people are able to access care at their community level. And then when it needs to go, you need to get further treatment, then you are referred to the main psychiatric hospitals or other places where you'll be able to access.
I am guessing that Dan's internet might not be cooperating in this minute. So Dan, if you can hear me, why don't you log back in and we'll pick it up from there. And the interim,
mental care.
oh,
So
you
the
got
issue,
now
we also
you're back.
engage
Perfect.
local groups that we work with for us to complete them. Yeah, so I think basically we work in the community level and are able to engage them and all of that. Thank you.
Thank you. Sorry about
The
that.
internet,
I did
the
cut
internet
in.
was misbehaving. The internet was misbehaving.
Yeah. Well, we're appreciative that it's worked this far. So fingers crossed for the next little bit of time. Let me turn to you, Alessandra. You've also had some really interesting experience around integrating services for people with disabilities into sexual and reproductive health services. Do you want to talk a little bit about HI's Humanity and Inclusion's experience in that area?
Sure. Thank you, Beatrice. In fact, among the different initiatives that HI has been promoting to promote health equity, the sector of inclusive sexual and reproductive health and rights has been the prominent one throughout the years. We have been organizing ourselves throughout the years in different ways. Most recently, one of the projects that maybe our audience is most familiar with is the Women's Integrated Sexual Health Program that was a FCDO funded program led by IPPF. In this situation, HI was the technical partner for inclusion, and we managed to promote disability inclusion in SRHR in the entire consortium and support the partner of the consortium to ensure that in the provision of services, but also in the other aspect of the project, persons with disabilities were included among the populations that were addressed by the project. The project was not exclusively focused on persons with disabilities. And it was what we managed to achieve is to, first of all, create this kind of consortium together with the other partners. That was one of the very first that really inaugurated the journey on inclusive SRHR of that size with that amount of funds available. Now there are many more, but that was already 5 years ago, and it was a very important start. And we managed to work at the community level, at the service provision level, and at the advocacy and government level, because each step of the way was really bringing together not only a perspective on intersectionality that we were referring to before, but also ensuring that each step of the way we could make sure that persons with disabilities are not only considered by the project, but meaningfully involved. So at the community level, working with organizations of persons with disabilities and women with disabilities-led organizations, at the service provision level, working with the training, with the health workforce and providing training whenever needed. And at the government level, collecting data through the other steps of the project and advocate for better policies. This is a formula that we have identified as a winning one, and that then we have replicated throughout the years. As a summary of some of the initiatives, in addition to the one that I have highlighted here, we have captured some of these lesson learned and recommendations in a document that I'm putting in the chat again for our audience. That really is a 4 pages document published by the HIPS that is really everybody knows it doesn't need any introduction, that really summarize some of the concrete steps that also needs to be taken into consideration by non-disability focused organizations when it comes to inclusive SRHR. Back to you, and happy to answer questions on this topic. Thanks a lot.
I'm going to jump to one last question. So I think we've gotten a feel for what's happening at an operational level. I'm going to challenge my colleagues to think about one thing, one lesson learned, or one tip that you would want others on this listening to us today to take away from this. So while you're thinking about that, I wanted to ask Anne specifically because she spent time looking at this from a donor and implementing lens. What would you say are the lessons that we can learn in global health from other sectors, and maybe specifically from other sectors and or from localization efforts? And then I'll flip to the colleagues for that one tip.
I think the important thing is inclusion doesn't just happen. It has to be intentional. So it starts at your gender and social inclusion plan and looking at diversity within that, going beyond gender. You need to have accessible materials, highlight success stories in empowering ways. So from the very beginning to the end. And that also means you have to budget for it. Especially for persons with disabilities, this requires reasonable accommodations. And it can be more expensive to have a sign language interpreter if you don't have that planned. You need accessible materials. Accessible meeting spots sometimes are more expensive in hotels that don't have accessible meeting spots. So you need to have the budget for it. I know that we're going to talk about the importance of partnering with these local organizations that represent persons of diversity, but you have to pay them. What we found in the education is that they're often asked to be volunteers while other groups are being paid. And this is something we have to move away from, and lessons learned to start well within the health department. So we're going to not only work with individuals, but pay them for their time as trainers and data collectors and advisors. Our staff that we hire for international need to reflect the communities in which we serve. And that means hiring people with disabilities as well. And we need to think about what reasonable accommodations they need in order to be effective staff members. We've done some embedding of persons with organizations, from organizations of persons with disabilities into the larger prime organization that allows them to learn about USAID and other funders. So I'd really recommend doing that as well. Sometimes we're going to need to train staff. All of us may have unconscious or sometimes even conscious bias that we need to remove about why we're not reaching out to all these marginalized groups. What are those barriers? And while we need to fully appreciate local groups, we still need to bring in some international expertise. We need to look at evidence-based practices. We've seen in the health sector, there was a push for inclusion, but it wasn't being done with evidence-based practices. And sometimes that push could inadvertently cause harm. And we weren't doing the best practices. Sometimes we reinforce segregation by doing it that way. So, and similar, I think the evidence base on inclusion in health and inclusion in all sectors is low. So I think there's a responsibility of all donors and implementing partners and people on this call to start dedicating more research to how to best include groups and what is the most effective practices to ensure their engagement. So, the education sector is not perfect, but there are some good lessons learned I think we can apply to health.
Yeah, I think some of those lessons health has learned in some other areas, like with the need to budget for paying for folks who have expertise, not just having them volunteer. So interesting resonance of lessons. All right, let's do a quick round of suggestions or tips. If you're to provide one or two concrete steps that those joining us today could take away from this and incorporate into their own work, what would that be? Alessandra, what would you suggest? What's your takeaway request from this?
First of all, because we are focusing on persons with disabilities, and not only, but when it comes from my side, I can make a recommendation on that. What we have concluded throughout the years is that standalone projects on a specific population do not meet the objectives of promoting health equity, and that this needs to be promoted in partnership, that organization of persons with disabilities and organization focused on disability inclusion like HI give the best while working in partnership with the organization that work, for example, on mainstream SRHR, if we want to use the word mainstream, or any other aspect related to global health. And so the recommendation is, even if you represent an organization that is not specialized on disability inclusion, this doesn't mean that you cannot or you don't have the tools to support health equity in the terms that are discussed in this webinar. The recommendation is to look for partners that can promote with you this objective, because none of us can do it on our own. HI has stopped standalone project focusing on persons with disabilities run only by HI, because we knew that this was not as important as it was not the best way to invest time, energy, and donors funds. There are some exceptions, but the major project that brings biggest result are the one that bring partnership. And when we speak about partnership, we speak about also organization of persons with disabilities, first of all, and women with disabilities-led organization that cannot be forgotten because they are the smallest, they are the one that receive less funds, but they can give a great support, considering that many organizations are often male-led and cannot always bring that intersectionality perspective that we are hoping for. So
I'm gonna stop. Is that good? Are you?
Yeah.
Okay.
I just wanted to close and give you back the mic. Thank you.
Thank you. Perfect. I'm just conscious of time, so I wanted to I think that's a nice segue to Dan. What is your, what's your one takeaway for colleagues listening to our conversation?
Okay, thank you, Beatrice, for this opportunity. Well, basically, it's been a very fun opportunity. I've learned quite a lot from the submissions made by my co-panelists, and the issue has to do with that kind of collaboration, that kind of intersectorial work and all of that. It's very, very important, because at the end of the day, we're looking at one main objective, that is to make sure that the underserved populations have access to healthcare, they have equity to healthcare and all of that. So that kind of collaboration, that kind of cooperation is very, very important. It's key to the issues of our work that we're doing. And also in terms of support from the donors, that is something that Anne has been able to act upon, for the donors to actually see what they can do in terms of helping us to be able to achieve our objective, to be able to serve the underserved population. And I thank you for this opportunity. I've learned quite a lot. Thank you very much.
Yeah. Anya, do you want to close on this topic?
Sure. I mean, it's a bit in line with what has been said. I mean, as I mentioned, I mean, a concrete step that anyone can take is to understand whether older populations should be reached by the programs that your organizations are working in. I mean, unfortunately, what I've seen throughout my career is that people are generally overlooked by organizations that work in areas that are directly relevant for older people. So and doing this simple exercise of seeing whether you should be reaching older populations often reveals very surprising information, which can even suggest a misalignment between our intended goals in the organization and the practices that we have, right? So for example, many organizations that are working to put an end to gender-based violence are maybe unconsciously, but they're excluding older women. We see that because data is only collected normally on gender-based violence, looking at women of reproductive age, which not only then leads to this inclusion, but also sends this wrong message that you may only experience gender-based violence if you are a woman of reproductive age, right? So we need to start considering this and ensuring that whatever work we're doing does not render a specific group invisible and prevents needed action in that space. And also, I think doing that will also help overcome silos that we see nowadays. So, for example, one thing that I keep seeing, and we have research that will be coming out fairly soon that's looking at the intersection between ageism and ableism in development and humanitarian practice and how it specifically impacts older people with disabilities. What we're seeing is that older people with disabilities, for example, are generally not included in efforts led by organizations working on disability. And similarly, organizations working on aging-related issues are often ableist in the sense that they're not including older people with disabilities. So again, there are huge gaps that stem from having these siloed approaches and not opening up and going through that exercise of seeing what our intended goals are in organizations, who we're reaching and who we're not reaching, and how we can, address any of those misalignments. So I would close with that, just, I guess, urging those who are hearing us today to go through that exercise.
Yeah, thank you. I know we're a few minutes over time, so let me just thank everyone for joining us. I hope that you leave with this sense that as health systems are advancing toward reducing mortality and achieving a greater sense of health and well-being for more people, that there are for more residents, for more citizens, that the time has come to extend availability and access in ways that require that we start by understanding those who the needs of those who would benefit from health services, but do not currently find themselves served by them in several different ways. And another place to start, beside understanding those needs, is by engaging with people who are in those groups in the countries that you're working with. So thank you all for joining us today. I hope thanks Global Health for sponsoring this event, a timely conversation around the global health landscape. And we look forward to subsequent and continuing these conversations in other forums. Have a great day.